Hi, Dr. Mark Agresti, and I'm here with my student Emma Lang. Say hello, Emma.
Hi.
And we're here today. We're doing a lecture tutorial on what is schizophrenia. Schizophrenia, let's take the word schizophrenia. Schizo means split, phrenia means mind. It's the Latin derivation of these words. It means split mind. And that's why there's a lot of misconceptions with this illness. It's not split mind. Schizophrenia is a psychotic disorder. This whole issue of it being a split mind, like dissociative disorder, where you have two personalities, it's not like that. It is a psychotic disorder in a group of disorders that fall into a class, schizophrenic spectrum disorders. There are some famous people with schizophrenia. Remember the movie A Beautiful Mind? Who is the actor in that?
That's the guy, John Nash.
Gladiator.
The guy.
John Nash is the story was about A Beautiful Mind, a famous mathematician, John Nash, and the actor was the actor in Gladiator, Russell Crowe. Then there's another one, Jack Kerouac. He wrote Big Sur, On the Road, Karma Bums. He's a very talented author. There's also guitarist Syd Barrett and Pink Floyd, and Peter Green from Fleetwood Mac. Now, what is schizophrenia? It is a psychotic disorder, which is a break from reality. And to meet the definition of schizophrenia, you either need to have delusions, hallucinations, disorganized speech, disorganized behavior, catatonia, or negative symptoms. Now, what does that mean? Let's take, to meet the criteria, you need to have these for at least a month, and one of the two need to be either delusions or hallucinations. Okay, what's a delusion? Emma, it's your shot. What's a delusion?
Pretty much just an unjustifiable belief.
See, that's good. A false fixed belief, an unjustifiable belief, something you can't sustain, does not work out in reality.
Yeah.
So a false fixed belief, and no matter how much you talk to someone, they won't change from that false fixed belief. For example, I had a patient who said, I have a Martian and I bleed green bloods. And then during the session, he cut himself on a piece of paper, and there was like a little bit of red blood. And I said, well, look, your blood's red. This is when I was young and foolish. And I thought, well, now his delusion is proven wrong. He says to me, oh no, the Martians are using a cloaking device. That's why my blood is red. They're blocking the green. So a delusion is a false fixed belief. What's the most common type of delusion? Take a wild guess.
Experience, or kind of that somebody is controlling you, somebody or something. You're not who you are, like you think that you're someone different than you are.
Okay, she didn't get that one right, but she's usually good. Poor Emma, I put you on the spot in a video, but that might not work out well for the fans out there. But what we have, it's paranoid. Like, I think the FBI is watching me. I think the CIA is. Paranoid, fixed, delusional systems. Someone's trying to get me. People are watching me. The neighbors are watching me. And that's a problem, and I'll tell you why it's a problem, because they react to it. If you think the neighbors are listening to you or going to attack you, you might attack them back. And I have a patient who actually did that. Mm-hmm. He was a police officer, and he took a pole and threw it into the neighbor's house because he thought they were watching him and spying on him. So we're talking about schizophrenia. One of the key components of schizophrenia, these are called the positive signs, are delusions. You either need to have delusions or hallucinations. You need one of the two. And you need 5 of the following: delusions, hallucinations, disorganized speech, disorganized behavior, or negative symptoms. And I'm going to explain what that is. Now, hallucinations. What are hallucinations? You want to take a crack at it?
Sure. False sensory input.
That's good. So you get a stimuli or no stimuli, and your body misinterprets no stimuli or the stimuli in the wrong way. So you have hallucinations, and they could be visual, auditory, tactile, smell, there are different types of hallucinations. The most common type of hallucination is
Hearing voices.
auditory. Good. I'm putting you on the spot. Is that
Yeah,
causing
no, that's
anxiety?
fine. No,
Okay.
I'm
all right.
fine.
Forget about the stupid video. We got to get this done. So the most common type is auditory hallucinations, and you have to be very careful because when you hear hallucinations, what's the first thing you think? You must find out what they are.
Telling you something to hurt somebody.
That's
violence.
very good because you need to find out, are these hallucinations telling this person to hurt me, to hurt themselves, or hurt someone else? You need to know. And do they control them?
Mm-hmm.
You know, there's hallucinations that tell you what to do, and there's delusions, experience of influence or experience of alienation delusions, right? Where you have a delusion that you're taken over by another power, experience of influence, or you are controlled by an alien being, experience of alienation, your thoughts are no longer your thoughts. Okay, so now another component is disorganized behavior. That's where their behavior is confused. They're wandering around the streets, you've seen it, talking to people, pointing a gun and pretend hand and shooting people, doing bizarre things. You know, in the streets of LA, San Francisco, New York, we see someone running around no clothes on and they're all disheveled and they have lice, and that's disorganized behavior. That's a component of schizophrenia. Now, another component of this disorganized behavior could be excitement. You've seen it. They get agitated. They run around. They want to hurt people. They want to hurt themselves. But there's something else called catatonia. Any idea what that is?
Just kind of a period of not talking, not moving, almost like...
That's very good. Catatonia is when you become mute, when you have automatic obedience, where, for example, the patient will sit there and you say, raise your arm, and they raise it. Put your arm down, put your leg up. Whatever you say, they do. It's called automatic obedience. There's something called posturing in catatonia. By the way, catatonia could be its own illness, or it could be a function of depression, or it could be a function of schizophrenia. But another thing is posturing, where they take a statue pose and they just freeze. So we have the catatonia could be mutism, automatic obedience, waxy flexibility, where you could put them in any position you want, or it could be posturing, or it could be negativism, where they respond to nothing. They just are completely empty and no response to the environment around them. I've seen catatonia, and we'll talk about the treatments for that later. So we've talked about delusions, we've talked about hallucinations, we've talked about disorganized behavior, which could be excitement or catatonia. Disorganized speech, that's another component. Let me get some tea. Disorganized speech is where they talk in tangential speech, where they go off on tangents, or they go circumstantial. They talk in circles and never get anywhere. Flight of ideas, they jump from thought to thought. Word salad, where they say, you know, the red green moon is eating the flying fish. It's word salad. It's a bunch of different words that make no sense. Now, they also, that's disorganized speech. Now we're going to talk about negativism. Any clue what negativism is?
being non-responsive.
Okay, that's right. I misused the word. It's the negative symptoms of schizophrenia. So now these symptoms need to last for a month, but the negative symptoms can be apathy, aimlessness, poverty of speech, lack of movement, lack of direction, amotivational, fatigue, social isolation. Those are the negative symptoms. Now, we've talked about these symptoms. What I've just described, you need to have at least two of them. One needs to be delusions or hallucinations. These need to be for a month. The overall deterioration in the person must be at least 6 months. Problems with family, friends, job, for at least 6 months for it to be called schizophrenia. If it's less than 6 months, it's called, if it's 1 to 6 months, it's called schizophreniform disorder. And if it's just less than a month, it's called acute psychotic disorder. These are pretty random, but just for completeness, I threw it in there. Now, when you have schizophrenia, you can't have schizophrenia if someone is taking marijuana, amphetamines, or cocaine, because these cause massive reliefs of dopamine and they mimic schizophrenia. Now, can they cause schizophrenia? No. But can they cause the age of onset to be earlier? Yes. So pretty much 100% of the people who use cocaine and they use amphetamine use enough, you will look like a schizophrenic patient. So if they do use it, it makes the illness worse, or it could precipitate the first psychotic break. So you can't really make a diagnosis if someone is actually using amphetamines, cocaine, or marijuana. Now, when is the first psychotic break? This is a little, take a wild guess.
Yeah, around 20 is kind of college age.
That's exactly right. It's 15 to around 23. It's earlier in men than women, and women it happens about 3 years later, and there is some evidence that in women it could happen a second peak of a schizophrenic first break in their 50s. It's possible.
Isn't it also more common in women?
I think it may be leaning towards women, but it's 1% of the population, and it's roughly evenly distributed. I'm not sure of the date on that. It's very close. Now, we haven't gotten a treatment yet. We're going to get into, let's go to treatment. No, I'm not going to treatment. I'll go to neurobiology. And what does that mean? What's going on in the brains of schizophrenics? Just a little bit about the neurotransmitters. And we talked about dopamine.
Mm-hmm.
And remember how we talked about how amphetamines, cocaine, and marijuana could bring on a break? Well, because it's excess dopamine.
Yeah.
So in the brain of a schizophrenic, they have an increased synthesis of dopamine. And that is believed to be one of the causes of schizophrenia. One of the neurobiological occurrences that happen in the schizophrenic mind. I'll get into the causes in a minute. We'll get to that. So what else happens in the schizophrenic brain? Their brains are not the same. We talked about this yesterday. They have enlarged ventricles in their brain. That's the area that contains fluid, like in this part of your brain, if you went in 2 inches. And their brains are smaller, believe it or not. Their overall brain volume is less. And also what they have is inflammation of the brain. And they have these glial cells. They have a gliosis, the inflammatory response in these glial cells. And what also could happen these are all good test questions.
Yep.
Also what the schizophrenic brain has is a decrease in N-methyl D-aspartate. That may be believed to be responsible for the negative symptomatology. And we talked about the different neurobiological, neuroanatomical. Just for completeness sake, the mesolimbic system is responsible from like the midbrain forward into the parietal lobe. This area right here is the hallucinations occur there. And from the midbrain all the way up into parietal lobe is a mesocortical. And that's responsible for the negative symptoms of apathy, amotivation, fatigue, social isolation, aimlessness. That may be responsible. There's tubuloinfundibular and nigrostriatal are responsible for some of the endocrine and motor problems associated. The nigrostriatal is responsible for motor.
Mm-hmm.
That's good, you know that. What are the causes of schizophrenia, Emma?
Excess dopamine on the synapse.
Wait, that's a neurochemical.
Yeah.
But how do people get schizophrenia? Yeah, you were right with causes,
Oh.
but that's like what's going in the brain that causes it. But I'm saying, what do they believe? How do you catch schizophrenia?
I mean, they have not found a specific gene for it.
That's exactly right. They don't know the gene for it.
Mm-hmm.
They don't know how you get it. But we believe it's a combination of genetics and environmental. There is
Right, it's a 50% concordance rate with monozygotic twins, as opposed to a 10% with dizygotic.
so what you just said was in identical twins, even if you have identical twins, both don't have schizophrenia. One could have it, and the other one only has a 50% chance of having it. And what they believe, it's polygenetic. There's no one gene. There is one genetic error. It's called the DiGeorge gene, and it's 1% of schizophrenia. It's like the 22q gene that is responsible for 1% of schizophrenics. But it's polygenetic, I mean it's multiple genes. But there's environmental things. Now, there could be when in utero, when you're pregnant with the baby, when the mother's pregnant, bacterial or viral attacks or obstetrical complications during birth. But there are also some key environmental things. What could they be? Sexual abuse,
Mm-hmm.
physical abuse,
Yeah.
emotional abuse, neglect,
Yeah.
death of parents. Also, if you're born in an urban area, you're more prone to get schizophrenia. People born in the country have less of an incidence than people born in urban areas. I don't know why. I guess there's too much stress in the urban areas. And the industrialized world has a higher rate of schizophrenia than the I guess the third world. So let's talk about treatment.
Seasons too, right? If you're carried or born in the winter, aren't you more likely? It's more common to have schizophrenia. Than
That's a good
born in the
point.
summer.
Good job, Emma. That helped. Okay, so now we're going to go treatment. Now, one would be supportive psychotherapy,
Mm-hmm.
and that's a type of therapy where we we support the defenses of the individual, we offer suggestions, we help problem solve, we help encourage positive behaviors, we work on hygiene, self-care,
Mm-hmm.
appropriate diet. It involves education, psychoeducation. It involves relationship issues. It involves real life situations in terms of apartments, bank accounts, helping them solve these problems. And as we were talking about this yesterday, in the schizophrenic person, because the executive part, the executive function of their brain, this part, the frontal lobe, is impaired,
Mm-hmm.
they need help with these everyday execution of problem solving. And don't underestimate with the therapy. I'm telling Emma this, but how important the therapist is. It's a difference between a successful outcome and a not a successful outcome. The therapist is no good, we're not going to have a good outcome here. And you're the most important person in that person's life. You're very important. They may see you once a month, but you're the most important person in their life. Now, that's supportive psychotherapy. We also use cognitive behavioral therapy, where we readjust the cognitive distortions of the patient. For example, the patient may say, "I'll never get better." That's not true. I say, you don't have a crystal ball. You don't know if you'll get better or not. And by the way, after the first psychotic break, a third of people go into remission. A third of people stay the same and continue to go along at about the level of that psychotic break, going into maintenance periods, but never getting worse. And a third of people get worse. So it's the rule of the thirds. So it's not the end of the world. A third of people go into complete remission, never have another break. Cognitive behavioral therapy, a person says, "I'm a failure," and you correct these cognitive distortions. I think I'm stupid, and just because you think something doesn't mean it's true. And you work on the cognitive and behavioral components of the person and try and get them into good behaviors. I mean, for the sake of keeping this short, I'm keeping this brief. Well, this is another lecture, cognitive behavioral therapy, but we try and get them into healthy behaviors, exercise, eating healthy, healthy social interactions. So we correct the cognition and the behavior of the patient. We correct cognitive distortions and behavioral distortions. And there's a saying in AA, fake it till you make it, get them into good behavior, they become good. So now we've talked about supportive psychotherapy, group therapy. These patients benefit from group therapy. That's where a group of schizophrenics enter into some group, and through the group process with a group leader, we bring about a therapeutic process to help these people. It's critical. It's community mental health centers, assisted living facilities, all have groups for these patients, and this goes on to this day. And then we have group homes for people with schizophrenia. And group homes is where they live in a supervised setting to help them with their everyday issues and problem solve. And there could be intensive outpatient programs where they go for the evening. There could be day programs where they go for the day. And there's community centers where they can walk in any point of the day that they want. It's called a drop-in center. And these things are all happening here in Palm Beach County and throughout the country where they have drop-in centers. Now, we've talked about the different types of therapy, supportive therapy, cognitive behavioral, group. We've talked about different types of IOP, intensive outpatient, group, day programs, drop-in centers, community centers. There are also for long-term schizophrenics state hospitals and where they go and they live in the hospital. Wait, I think I'm missing something important here. I'll get back to it. Then, psychoeducational groups, where we educate them on the different things that they can expect. Medicine side effects, coexisting addiction problems, coexisting depression problems. Schizophrenics are more prone to be victims of crime than they are to be actually hurt people. So we have to be real careful with that. Everyone thinks that psychotic people are predators. No, they're the victims. The most dangerous person is a bipolar manic patient. They become violent. The schizophrenic, no. Schizophrenic is usually the victim of crime. You usually see those people running around yelling and screaming at people. Well, eventually someone beats them up, shoots them or stabs them. Or in New York, when I was there, they poured lighter fluid on them and lit them, or they would just beat them to death on the street. So they can really run into problems. Now I want to get into, there's the medicines, the antipsychotics. These people are psychotic, so we give them antipsychotic medications. There's the new generation medicines and the old generation medications. The new ones, Latuda, Abilify, Zyprexa, Quetiapine, Invega, Risperdal, Geodon. You getting all these? Any that I'm missing? Those the old ones are Navane, Prolixin. A famous one is called Haldol. Another famous one is called Thorazine. I haven't gotten them all, but I've gotten probably 95% of the ones that are used. What's the difference? The older ones, they work well, but they don't treat the negative symptoms, the apathy, social withdrawal, negativism, social isolation, aimlessness, poverty of speech, poverty of thought, decrease activity, decrease executive function, decrease animation in their affect. That's another net where they're blunted, they have a masked face. We talked about that. There also is something which I'll talk about in a minute. The rate of tardive dyskinesia, which I'll get to and explain what that is in a minute, is 4% a year in the older medicines. It's 0.4% in the newer medicines a year. And I'll talk about what tardive dyskinesia is. So we use the newer medicines because they don't medicate people. They don't appear as drugged. But listen, everything's got its problems. These medicines can put on weight, causing a metabolic syndrome, diabetes resistance. They can cause this tic formation. It's called tardive dyskinesia. I'll get into that in a minute. They cause elevation in cholesterol, elevation in triglycerides, all of them. They cause elevations in prolactin, which can cause lactation in women and breast formation in men. But they stop the hallucinations, they stop the delusions, they stop the disorganized speech, disorganized behavior, they stop catatonia. We use the newer ones because the risk of causing this tic formation, which I'm going to talk about in a second, is 10 times less, and the negative symptoms of apathy and aimlessness and social isolation, it treats better. Now, what is tardive dyskinesia? Every patient who has schizophrenia, we have to talk about this. What is tardive dyskinesia? Tardive dyskinesia, because we're affecting dopamine, and dopamine is involved in that nigrostriatal pathway, which is a motor pathway of the brain. And when you block the receptors of the dopamine, that's all these drugs do, is they block dopamine. Now the receptors, the body doesn't like that, so it makes more receptors and makes them more sensitive. And now something called homeostasis, the balance between the neurotransmitters of dopamine and acetylcholine, is thrown off. And what happens? People develop a tic, a tapping of their hands like this, or a rabbit syndrome. They move their nose like this. Lip smacking. You ever see that? Or then they can move their heads like this. Or they may develop restless leg syndrome. This gets more complicated. There are some temporary side effects that these medicines can cause, which are extremely unnerving. It's called dystonias, muscle spasms, and restless leg syndrome called akathisia. That's temporary and can be treated with anticholinergic drugs like cogentin. Benadryl can help. So these are temporary side effects of muscle spasms and restless leg. The tic formation, which is important, is permanent. That's the problem. Because these people, once they get it, this could be permanent. The more medicine you give, you can mask it temporarily, but it makes the tardive dyskinesia worse. So it's a nightmare. And it's disfiguring. It leads to discrimination. It leads to these people being marked as psychotic and schizophrenic, because now they're walking around with tics, and they could have tics of their trunk, their legs, and they don't go away. Up to about 4 years ago, this was a permanent, severely, what would be called cosmetically harming illness. But then treatments came out, Ingrezza, valbenazine, and Austero, tetrabenazine. And for the first time, we have to use these antipsychotic drugs. They left these permanent, disfiguring tics called tardive dyskinesia of the whole body, the mouth, the face, the trunk, the legs. And really, you couldn't stop the medicine, because if you stop the antipsychotics, these people would lose their identity and just walk around psychotic, like completely disorganized, inappropriate, agitated, or catatonic. But then when these new drugs came along, they're called Vesicular, Monoamine, Oxidase inhibitors, VMAT, Vesicular Monoamine transporter 2 inhibitors. They were lifesavers, because now you could treat tardive dyskinesia and you could make it go away. After about 6 months, you could try and stop it, and maybe it goes away, or maybe you have to continue the treatment for life. But at least these people aren't having these cosmetic symptoms for life. This was a major breakthrough. So there is hope now where you can treat these. Now, these drugs have a host of other problems. I talked about them causing weight gain, which stigmatizes the schizophrenic, high cholesterol, high triglycerides. They can induce insulin sensitivity and diabetes. They cause these motor problems, which could be these tics, tardive dyskinesia, which could be permanent. They cause these akathisia, which is this restless leg syndrome, or muscle spasms, which you can treat, make them go away, but it's still disfiguring. But there's something even worse. You just can't win in this life. There's something called neuroleptic malignant syndrome. And it is an acute crisis and a deadly side effect of these drugs. And we got to use these drugs. Otherwise, you lost the identity of the person. So now I'm trying to talk people into taking these drugs. No wonder compliance is a problem. But neuroleptic malignant syndrome, anything about that? That's new. This is a deadly complication of all antipsychotic drugs. And what does it look like? Muscle rigidity, fever, their blood pressure, their breathing, their heart rate is labile. It's all over the place. And they get delirium, clouded consciousness. I've seen this in the hospital. Trust me, it causes chest pain to the psychiatrist because you have to treat it, and you have to treat it quick. Otherwise, these people could die. And then they get increased white neutrophils. So that means white blood cells. And so what happens? Well, they're sitting there. They're all tight. They're tensing up. They're almost like seizing. They're making no sense. They're delirious. They're in a bed. They're shaking. And what happens is the body starts dissolving itself. The muscles start breaking down. And the muscle tissue starts getting cleared by the kidneys. And the kidneys shut down. They die of kidney failure. So you have to deal with this extremely quickly. Neuroleptic malignant syndrome is a nightmare. So what you have to do is get fluids in them right away. Usually it's the ICU or the emergency room. 20 years working psychiatric emergency room. This is what you got to do. You have to stop the muscle rigidity with either a benzodiazepine like Ativan. Am I losing you with me?
Mm-hmm.
She writes very neatly in good notes. So you have to do stop the muscle spasms with either a benzodiazepine like Ativan, and you give it IV. You need to hydrate them. You need to use dantrolene, which is a muscle relaxant. It effects on calcium. You need to get that fever down with aspirin or Tylenol. You need to, because it's from the antipsychotics, you need to stop them, and they block dopamine. And you need to give something called bromocriptine, which gives a pulse of dopamine. So stop the antipsychotic immediately and give them a drug called bromocriptine, which promotes the dopamine. And so we have hydration, muscle relaxants with benzodiazepines like Ativan or dantrolene, increase dopamine with bromocriptine, bring down the fever with aspirin or Tylenol, hydrate. People usually come out of it. No one's ever died under my care for this, thank God. But it is a problem. So now, I've talked about a lot of this stuff with schizophrenia. And Emma, what do you think the life expectancy of the schizophrenia is going to be, longer or shorter than you and me who don't have this illness? Probably
Shorter.
yes. I gave her some hints, but so it's shorter, and I'll tell you why it's shorter. You know what schizophrenics do because it helps the illness? They smoke. And what does smoking do? It leads to heart disease, right? And it leads to lung disease. So they die at high rates of heart and lung disease. You know what else they do? They don't eat well. Poor nutrition. They eat what's available. Processed, fast food, and junk food, usually packaged stuff. You know what a schizophrenic eats for breakfast? A Twinkie, or a packaged piece of cake, or a cigarette, a cup of coffee, and what are those things? Egg McMuffin. I had one here today. I said, what do you have every day? One of these McCoffees with sugar and Egg McMuffin. What do they have for lunch? Candy or a soda. They're always drinking soda. What else do they do? Because of the medication, they get diabetic. They get fat. They get overweight. They have coronary artery disease, and they're smoking. They have high sugar diets, high fat diets. They get coronary artery disease. And that's what kills them. Coronary artery disease. The diabetes, coronary artery disease, and lung disease from smoking. It gets worse. So once you have those, your immune system is already compromised in diabetics. You get peripheral neuropathies. You're prone to get sores. They don't heal well. You smoke and you get sores. They don't heal well. You're much more prone to infection. And guess what schizophrenics don't do? They don't bathe every day. They don't brush their teeth. They don't clean their hair. They don't exercise. They don't take care of themselves. So they get all these sorts of these infections and lung disease. That makes sense, right?
Mm-hmm.
Can you think of anything I'm missing there?
I mean, just a question. Is there higher suicide rates among schizophrenics than the general population?
Dramatically higher. I was just getting to that. That was one of my next things. There's higher rates of suicide. There's higher rates of homicide. They kill themselves. They get killed, and that's why their life expectancy is 20 years less. And also in our system, they wind up in our jails because they do things that they break laws for ridiculous reasons, like loitering, trespassing, living in parks, annoying people, harassing people, urinating in public, defecating in public, using drugs or drinking in public. They don't pay tickets and they get put on probation. They can't follow probation, so they wind up in jail where they're usually beaten and tormented, and living on the streets where they're arrested. It's horrible. Okay, we've talked about treatment, epidemiology, neurobiology. We've talked about complications of the drugs. We've talked about the symptoms. Let's see, did we miss? Oh, sorry. I think we talked about catatonia. Anything else you could think of? I think we're pretty good.
Yeah, just another question.
Sure.
So how would you decipher between if somebody's schizophrenic than like another disease like Huntington's or something where delusions and hallucinations are also present?
So that's a good question. The schizophrenic spectrum of disorders, schizophrenia lasts for 1 month of positive symptoms, delusions, hallucinations, disorganized speech, catatonia, excitement, disorganized behavior, and negative symptoms, and 6 months of a deteriorating picture. It's the constellation of symptoms, right? So when you have Parkinson's is a disorder of motor. Parkinson's does not present with a psychotic break. Parkinson's presents with cogwheeling, a difficulty initiating behavior, shuffling gait, masked face. So it's a motor disorder. But as Parkinson's progresses, Parkinson's turns into psychosis, dementia.
Mm-hmm.
But its initial presentation is that of motor and difficulty standing up, truncal weakness. They can't initiate behavior to stand up. They shuffle their gait. They write, it's called micrographia, very, very small. So it's the constellation of everything. So in a schizophrenic picture, it's at least a 6 months deteriorating picture, but they have to have delusions, hallucinations, and they have to have disorganized speech, disorganized behavior. You don't have that in Parkinson's. They talk fine, they think fine for years. Before they get psychotic, they could have the illness for 20 years. Where schizophrenia, it happens day one. When they have their first psychotic break, it's there. So it's the constellations of symptoms, and even though two disorders share common symptoms, they're different. And there's a timeline. If it's less than a month of psychosis, it's called acute psychotic disorder. If it's 1 month to 6 months, it's called schizophrenic disorder. And if the psychosis lasts more than 6 months, it's called schizophrenic disorder in the spectrum. And schizoaffective disorder is, in the absence of having psychotic symptoms, they have mood problems, mania or depression. Did I answer that?
Yeah. Mm-hmm.
And did we talk about other disorders? And we have to look at the constellation of symptoms.
Right.
It's everything together. That's what makes a disorder. Even though disorders share commonality in signs and symptoms. What do you think? We covered it?
Yeah, I think so.
And we were talking about this was giving Emma fund of knowledge, but there's also functional knowledge where she's learning to interview and she's learning to interact with people. So it's not just these type of interactions I'm having with Emma.
Sorry, one quick question. So,
Sure.
We talked about the difference in brain structures with schizophrenic people compared to neurotypical. Do you see these differences, like enlarged ventricles, hyperfrontality, things like that, at birth, or as soon as you see these behaviors?
That's a good question. Do you see these at birth? Some of them you do see. You do see decreased brain size, and you can see increased ventricular size, but you begin to see a white matter decline after the first psychotic break, and then it usually stabilizes, but gray matter continues to deteriorate and becomes less gray matter over time of the illness. So that's why we call it the downward spiral of the illness. As they lose gray matter, their ability to function becomes less and less. And here's another important point with schizophrenia. With each psychotic break, they don't return to baseline. So they may be functioning at a high level, psychotic break, they don't come back to where they were. There's the neurotoxicity of psychotic breaks. That's not just with schizophrenia. When you become psychotic, the longer the psychotic period, the more severe, the more the person deviates from their baseline, it deteriorates. The more psychotic breaks, the more that person deteriorates, and the less they go back to baseline, so their level of function deteriorates over time. And all forms of psychosis, whether drug-induced, whether psychotic or bipolar, cause neurotoxicity. Psychosis of every time destroys your brain. It's like a fire burning on the electrical circuits of your brain. And that's why people decline over time. And that's a good question. I forgot to bring that up. See, it's good when I do it with Emma. Can you think of anything else? That's really important, the neurotoxicity. And that's why it's so important for compliance with medication. Oh, that's another thing we have to talk about. What do friends and families need to do with the schizophrenic patient? No expressed emotion, no yelling, no screaming. You talk to them in a very gentle, supportive, friendly. It takes a village. Everyone around them needs to be suggestive and encouraging, never punitive, never like, you need to eat better. No, let's say their name is Joey. Joey, we have some good food for you today. Maybe you'd like to have some fruit or guacamole or almond yogurt or oatmeal for breakfast, and not eat that piece of cake for breakfast or that bagel. And you encourage them. And when they say, well, I don't want to take my medicine, I think it's a good idea. We spoke to the doctor. He thinks it's a good idea. Maybe you should take your medicine. Don't get in a fight. Don't yell. Be supportive. Be kind. Be gentle. And offer suggestions. Never punish. Never withhold love. Never yell. Never say, you're a complete idiot. If you don't take the meds, you're going to get psychotic. You're going to make everyone's life miserable. That's the worst thing you could do. No, I think it's a good idea you take the medicine. It's helpful. We have to be aware that if you don't take it, you could hurt your brain. I hope you do take it, and I hope you choose wisely today, Joey. No EE, expressed emotion. You're very gentle, non-punishing, non-punitive. You offer suggestions, you offer encouragement, and always positive. You did a good day yesterday when you took the medicine. Why don't we take it today? And get help immediately. If you don't put these patients on medicines right away, they deteriorate and they don't go back to where they were. You must keep them on the medicine. Yes, I know it causes those bad things, tardive dyskinesia, neuroleptic malignant syndrome, diabetes. I know it causes increased cholesterol, and I know it may lead to coronary artery disease, but without it, the very essence of that person is gone. They fail to exist as an individual and a psyche. So without the medicine, you lose who they are. Hey, I've had people going into coronary artery disease or having renal problems or heart disease, and I said to the cardiologist, I said to the nephrologist, I can't stop the medicine. If I stop it, all's over. This person no longer exists. So you cannot stop the medicine no matter what's wrong. When you stop it, they become psychotic and they start running around the street. I had one woman, I tried stopping it when she was becoming diabetic, and she took her clothes off, ran around nude in the neighborhood. She cut all her curtains, and she put a pillow over her son's head to suffocate him. She cut the curtains in the house, tried to kill her own son. And the husband's like, Doc, I don't care what happens to her on the medicine. I'd rather have her die on medicine than to do this. It was horrible. And it got horrible really quick. So you see why we push the medicine? You gotta have the medicine. It gets so bad. Yes, I have trials because people can go in remission, and I do try and to back off. But if I see the psychotic symptoms coming on, you gotta put them back on. Is that reasonable? Make sense? Thanks a lot, everyone out there. And I go into this in depth in my book. Let me get the book. I have a chapter. It's really interesting. I spent a lot of time on it. It's in my book, Tales from the Couch. I'm a relentless marketer too. It's chapter 3. Isabella lived in a world of aliens. It's a totally true story. I try and disguise the patients, but Isabella is a real person, and she lived with schizophrenia, and it's really interesting what happens. Like that movie with Russell Crowe, A Beautiful Mind, this is very similar. You can get my book on Amazon.com. And Emma, thanks for cooperating with this exercise.
Thank you.
Okay, bye-bye.